Hello and welcome to this talk on the rules of the emergency department, clinical decision unit and sick patients for the Princess Royal University Hospital emergency department. My name is Paul Schofield. I'm one of the emergency consultants. I just want to acknowledge some help that we've received from documents published by Derriford Emergency Department in this talk. Firstly, we should consider that for some of you, this will be the first time you've not been working in a ward environment. So we should go through the rules of the emergency department, the rules of the clinical decision unit, how to spot and manage sick patients, and also, unlike most specialties, we are primarily a referring specialty. So we'll go through how the emergency department referrals work here at the Princess Royal. First things first, a few admin things. Please turn up for work on time and dressed for work. Remember, this is a working environment. We're not expecting three-piece suits. You should be dressed appropriately. Bare below the elbows. Avoid low-cut tops, short skirts, bare midriffs. If you feel comfortable in scrubs, feel free to wear scrubs. Please do not go home until your replacement doctor is on the next shift, unless the epic says it's fine for you to go home. You're no support for your patients, though, if you do not look after yourself first. So make sure you take your breaks, keep a full stomach, and you empty your bladder as you need to. Please, please, please call the epic just after 8 o'clock if you're going to be sick. You don't need to tell us why you're sick, but certainly if there is a infection control issue, please let us know as soon as possible. And also let the rota coordinators know of any swaps in advance, because you can only swap within your own rota. This is purely so that we can maintain safety of the department. When seeing patients, and also remembering your colleagues, please treat people as you would like to be treated yourself. Wearing your name badge, saying hello, making sure that you're polite. We are going to be mentioning this a few times, but try and avoid transmitting infection. Remember to wash your hands. In this era of coronavirus, remember your appropriate PPE. Dispose of the sharps in the sharps bin. Nobody wants to get a needle stick. Remember when you're speaking with a patient to warn them about possible complications of the treatments we're offering. But also make sure that we give pain relief. No one is going to thank you for making a clever diagnosis if they're in pain the entire time. Think about rationalising for any follow-up or prescriptions before organising this. Are they going to be able to get to a hospital appointment? Could they get a relative to pick up the prescription? If you do make a mistake, you are only human, but please apologise and let the epic know. Going back to the infection control, remember to clean up after yourself. If anything you are wanting to use you find isn't working, or that you've used the last piece, please let someone know so it can either be fixed or replaced. The nursing staff will not enjoy chasing you for your patient plan, so please let them know and include adding it onto the patient plan component of Symphony. And before putting any patient into a cubicle, remember to ask permission of the nurse in charge. The most important thing about seeking advice is first see the patient. If the epic or doctor in charge of an area hasn't given you advice before seeing the patient, the first piece of advice will be to see the patient. Unless we specifically state otherwise, advice should only come from emergency department seniors. Please let us know if there are any clinical administrative problems, else if we don't know about them, we can't fix them. Some specialties seem to think that they're there to provide advice. We are asking them to see the patient. They're being asked for it to take a referral. Always consider a coherent differential diagnosis and potential management plan. It will improve both the advice you're going to receive, but also your learning behind that advice. Please do not canvass different senior doctors for advice. It's a guaranteed way to get 4 different plans in an emergency department is to speak to 3 different emergency doctors. We're all different, but if you ask us each the same question, you will get a different and potentially conflicting response. If going back to the thing of seeing the patient before asking for advice, if we offer you advice without you asking, there's probably a very good reason. And if any senior or experienced nurse advises you to do something, think carefully before ignoring it. Documentation. Most of our documentation is done on paper, but we do use electronic communication with the GP via both Symphony and EPR discharge letters. Please, please, please write legibly. I'm one of the worst at this, but it will be what you can stand up in court with in 5-6 years' time. If you can't read it, no one else can. Make sure you put your name, your grade, the date and times in the notes, and write the results of any investigations. You'd be amazed at how many things have plan, bloods, x-ray, and that is the end of the notes. Keep your notes concise and focused. We don't expect you to spend hours writing each set of notes up. Please make sure that the notes are written when the patient is discharged and don't batch your notes together. And when you discharge the patient, keep the discharge letter brief and to the point. No GP is going to want to wade through pages of discharge notification for a simple sprained ankle. Remember, if you didn't document it, it never happened. Unfortunately, performance indicators and targets are a way of life, and the emergency department has many. These include time for the first clinician and how many patients we can see, treat and discharge or admit within 4 hours. The performance indicators of the department not only flag well or badly against the department, but the whole hospital. There are, though, certain patients where it is not just important how quickly they are seen, but also that they get senior reviews. And you can see on the slide that these will include adult chest pains, returning patients, and under ones with a fever, although most of these are seen directly by the paediatric team. Investigations are important in trying to establish or rule out parts of your differential diagnosis. It's important to consider certain things. Always look for a second fracture on an x-ray. Just because you found one abnormality does not mean that's all there is to be found. Any woman who could potentially be pregnant is pregnant until proven otherwise. So things such as syncope or abdominal pain can all be symptoms of a ectopic pregnancy, and no one will thank you for missing that. Please, please, please do not go through a battery of investigations just to find something abnormal. The amount of times we get abnormal results that we never wanted the test done in the first place. When you're learning to review x-rays, always get a senior to check them with you. Please do not add or order tests for other specialties. If they want them, it's very simple for them to add. A normal ECG does not exclude a myocardial infarction or significant ischemic heart disease, much as a normal CT does not exclude a subarachnoid hemorrhage or stroke, and a normal X-ray does not necessarily say there is no fracture. So if there is clinical suspicion, we need to continue it, even if the investigation on first glance would appear normal. When you're at work, it is not just pure service, so when you see a patient, and each patient will be different, try and think about what learning things you can take from that patient. Please do not cherry pick patients though. If there is a patient to be seen in a higher triage category, typically your T2 patients, or we want a patient seen earlier, the EPIC will normally tell you. Otherwise, it should be the next person in time order. Whilst you're waiting for a bleep to be answered, perform other things such as writing the notes, writing up analgesics, etc. So you need to learn to multitask, which is not something easy at all. We are aware you're no robots, and it's fine to talk, but please do not make it when busy and patients are waiting. That's how we get complaints. As I mentioned earlier, the admission, assessment, discharge target of 4 hours is one of the key emergency medicine measures. We also have a clinical decision unit for patients who, with a little bit more time, rather than admitting to an inpatient specialty, can be discharged. Currently, there are 9 spaces, but some of these are being used for majors patients because of the coronavirus quarantine requirements. So we need to be careful of what goes on to the clinical decision unit. There are various pathways. Please stick to them. And remember that if somebody is going to be admitted onto clinical decision unit for any length of time, they will need a discharge summary when they leave and their regular medications, which would include Parkinson's medications for any Parkinson's patient, even if they're just waiting to be discharged home with transport. So now we've gone through the admin type things about working in the emergency department. We should consider the actual patients, which, let's face it, are the reason we are here. Now, some of our patients are sick, and you may end up being the first person to see them. Now, we might say somebody is sick because they've got abnormal vital signs, or they may have an abnormal history which suggests they have illness. But they can be anywhere. Just because they're not in resus, let's remember resus is just a room. So if a patient is in the resus area, it will generally mean somebody else has thought they might be sick. And there'll usually be a senior emergency doctor with you, or at least has reviewed the history before deciding they're sick and need to be seen now. If there isn't, though, you will need to consider using a structured form of assessing the patient, and always get senior help when you feel like you're struggling. Initial assessment of the sick patient in the emergency department is very much on the ABC principles that, if you're not already aware of, you will become aware of as you develop through your career. And that is airway, breathing, and circulation. If there are major issues with any of these, call for help immediately. If not, we can use the acronym MOVE to work out what to do next. So MOVE stands for monitor, which is ECG, saturation probe, and non-invasive blood pressure. Oxygen, appropriate delivery for appropriate target oxygen saturations. This might be a high flow face mask. It may just be nasal specs. It may be air. Venous access. Generally, in the emergency department, bigger is better. So we're thinking of an 18 gauge, which is a green cannula, or bigger. And then further evaluation, which gives you the E. This is where you get your 12 lead ECG, you do your focus history and examination. It will not take you long to hear the tannoy going off repeatedly, asking for many things, but one of the key ones to listen for are blue calls. That may be an ED resus team blue call, a paediatric resus team blue call, a trauma call, or a stroke call. And if you hear the blue call go off, it will generally mean that a patient is coming in. This is your opportunity to get involved. So if you're allocated to be the junior on for resus, please listen out for the blue call going off and try and get into that resus area. There will be an ED senior, either a registrar or consultant, who will allocate roles. It may be initial assessment, bloods, IV access, but later on, as you gain in confidence and experience, this may be the whole emergency department part of care with supervision. Sick patients in other locations within the emergency department, though, can be a lot harder to identify. But as I said, the recess room is just a room. There is nothing magical about those four walls. There are some classical things that often get misdiagnosed, especially from triage. The muscle strain that is an acute myocardial infarction. The migraine, which is the subarachnoid hemorrhage. The urinary tract infection, which is in fact an ectopic pregnancy. Or the classic renal colic, which is the rupturing aneurysm. And these all end up getting mistriaged, and as a result could be almost anywhere, even the waiting room, but are actually incredibly sick. As a result of this, when you're seeing a patient, you should consider what is the worst diagnosis we can think of. If you don't think of it, you won't make that diagnosis. So for example, if you see a presenting complaint of a chest pain, or back pain, or headache, make a mental consideration of what is a differential diagnosis I must not miss with this presentation, and adjust your history to ask the relevant questions for that. Now, you may be at a loss to understand what is even the role of emergency department and the emergency medicine. And it has to be remembered that this is a young but important specialty in its own right. The days of the casualty officer are long gone. And what we are experts in are resuscitation, the diagnosis and immediate treatment of the undifferentiated patient. And this will include discharging and accepting of risk assessment. Some patients, though, we feel need admission, and these we refer to what we believe is the correct specialty. As a result of this, we are very much a clinical specialty. We base our diagnosis on history and examination rather than necessarily performing a battery of tests. And that assessment and clinical decision making is the centre of what emergency medicine is about. For most of you, emergency medicine may not be your end career goal, but even that, clinical decision making is the hallmark of being a doctor, and it is much more common and crucial than technical skill proficiencies for the vast majority of specialties. You are the data gatherer who becomes the decision maker. And the rapid number of patients that you will see in the emergency department is the perfect place to gather and develop those skills. So when we're making these decisions, we're basically starting from, do they need any immediate resuscitation or immediate treatment? If not, we're then thinking along the lines of, can we discharge this patient, or do they need admission? And if admission is the end route for their emergency department journey, which specialty is best appropriate for them, what we want that specialty to do, and what ED treatment do we need to give? Equally, if we feel they can be discharged, have we given the right treatment? And what advice do we need to give, both for returning if things get worse, but also for follow-up that they may require? And it is important to consider trying to make these decisions as early as possible. It doesn't just benefit the current patient you're seeing by speeding their journey, but because you are making that patient's journey more fluid and efficient, the patient behind them has less time to wait, and we know that for many things, time in the emergency department has a long-term outcome benefit for the patients. So how do you actually even make a decision in the emergency department? It is primarily history. History, history, history. It's always going to give you an indication of where things are going. There will be some patients where we don't get very good history, either because of confusion or they just do not remember what happened to them. Secondary things will be our focused examination. We discussed earlier about thinking about the worst. Before seeking help from the seniors, try and consider, what is your differential diagnosis? If it is chest pain, it might be, is this a myocardial infarction? Is this a pulmonary embolism? Is this pneumonia? Is this heartburn? And then discuss with the seniors as appropriate, who will advise you on what tests to carry out. How long this takes varies. For a majors type patient, it can easily take around the hour to get the history, the examination, and formulate your management plan. And we can see here the form that a junior doctor decision making may take in the emergency department. With the development of technology in medicine, there's been a move towards testing to the point of exclusion and an over-reliance on testing to aid decisions. So think, do I need that test? Do you really need to know if somebody is vitamin D deficient in the depths of a London winter? Only wait to refer if the results will make any differences to the decision or emergency management. For example, a COPD patient needing oxygen, although a chest x-ray may alter their initial management, waiting for the liver function tests or a CRP is of little value. But ED treatment must still be given, so we should still be thinking for that same patient of giving them steroids and nebulizers as appropriate. As a result, it's often only necessary to wait for all tests to come back if the plan is they can go home. So if all their bloods are they're normal, which may not be the normal parameters for the population, then they can go home. Some patients will occasionally be able to go home whilst awaiting their results, but this is a very small group in the emergency department. And if that is your plan, please make sure you check them and inform the patient, and you have a reliable way of contacting them. The time to get a test result back can be highly variable, and this can be significantly more if we add the test on later. So do choose carefully. Just doing a battery of tests will just delay that patient's journey for no apparent reason. So if you don't need to have a B12 or folate or ferritin, don't request them. On certain occasions, it might be appropriate for specialist advice to be requested. These will be the patients where we think they can go home. And if that is the requirement, that advice should come from a senior in that specialty. It should not be the junior SHO. And if at all possible, please ask the seniors in the emergency department. There will always be a senior decision-making doctor within the emergency department, 24 hours a day, 365 days a year. Some of you may have already experienced being the receiving end of referrals and just feel that the emergency department just refer everything because all they want to do is get people out within 4 hours. Generally, we are trying to discharge people, and when we refer, it's because we believe that the inpatient specialty is needed for that individual patient. We're not asking for permission, and they must see the patient and write in the notes. And they should not be demanding tests to be done and then calling back 20, 30, an hour later. Once they've seen the patient, there is no refer back to the emergency department. If they feel it is more appropriate for them to be seen by a different specialty, they should refer on themselves. Having said that, it's important to consider before you pick up the phone to bleep, what is it you're going to say? So you should be thinking, what is the reason you're asking? Why do you want that specialty to see them? Be sure of what you're asking for, but be polite. This way of doing this is to use something such as the S-bar structured referral. And we can see here what the S-bar timetable. So situation, background, assessment, and request what you want them to do. So an example would be, I have a however many years old man, woman who needs admission for, and go with your big what you think this is. What is the diagnosis you really need to rule them out? And that might be the cauda equina, the acute coronary syndrome, the pulmonary embolism. And if the emergency department registrar or consultant has been involved, state so. Early on, you will be getting us involved with every single one of your patients. It's reasonable when you're saying what you think is wrong to include the history. So if you're referring someone with presumed cholecystitis or pancreatitis, the fact that you know they've had gallstones and they've previously been under the surgical team is important to consider. Inevitably, sometimes you will get some feedback from the admitting specialties that is not the greatest in the world. If that happens, please get one of the seniors involved as soon as possible. Also do the same if you think that a patient is being dangerously managed, either by an inpatient specialty or one of the emergency department staff. So, if you have any questions, obviously raise them when you're on the shop floor to one of us, but we will also be having clinical educator sessions, which will include one-to-one following by one of the consultants. So raise those questions as you think of them. So we've gone through the rules of the emergency department. What is the clinical decision unit for? Basis of how to manage a sick patient and the principles of referral. Hope this video has been of interest and hope to see you soon in the emergency department of the Princess Royal. Thank you and goodbye.